Combining repetitive transcranial magnetic stimulation with psychoformal therapy. Outline of presentation, objectives, case study, defining treatment-resistant depression history and physical, working nursing theory, focus, clinical PICO question, evidence-based research criteria, purpose of this evidence-based research, breakdown of transcranial magnetic stimulation, medical uses, advantages and disadvantages, evidence-based findings, key research findings, implementing findings to the case study, references, and questions. Objectives: to increase the knowledge of being able to recognize and diagnose treatment-resistant depression, to educate the audience on transcranial magnetic stimulation as adjacent treatment in TRD, and to improve the effectiveness of treatment in the patient involved in this case study. Case study: 54-year-old Caucasian female presented to clinic with complaints of anxiety, panic disorder, PTSD, and bipolar disorder, in which symptoms of mania has been managed. Patient reports that she has not been sleeping at all, having trouble, nightmares. Patient also reports that her mood has been quite irritable. Patient states that she has constant anxiety and rates her mood 8 out of 10, with 10 being the worst on depression scale. As stated above, patient has an underlying history of bipolar disorder in which the mania is controlled by depression is not, but depression is not. Patient has long-standing history of major depression and resistance to antidepressant. She also was diagnosed with major depression approximately 15 years ago. According to patient's medical history, patient failed to respond to SSRIs, SNRIs. Now we're going to define the treatment-resistant depression. According to WHO, which is the World Health Organization, major depression disorders was classified as third in the global disease burden in 2004, ranked first in middle and upper income countries. Over 30% of these patients are unable to achieve a response to antidepressant medication or psychotherapy. TRD is a term that is used to describe cases of major depression that does not respond effectively to appropriate courses of at least 2 antibodies. TRD has become one of the most significant and persistent complications in the field of psychiatry. Factors that predispose, as in the case of our patient, TRD is more prevalent in bipolar depression than in major depression disorder. Comorbidity, anxious symptoms, and full anxiety disorder, especially generalized anxiety disorder, were found to be predictors of lower rates of response and remission, like a sympathetic improvement within the first couple of weeks since the start of treatment. Old age, subtherapeutic doses of antidepressants, approximately 20%. Patient non-adherence, approximately 40%. Intolerable adverse effects, 20 to 30%. Wrong diagnosis, 10 to 15%, such as thyroid disease, nutritional deficits, sleep apnea, and latent bipolar. Duration of the episode. The longer the episode of depression, the greater the atrophy in specific brain region. The cognitive and behavior changes that take place during long episodes make a return to previous well-being difficult. History and physical. Past medical history. She had acid reflux, constipation, migraine, seasonal allergies, essential hypertension, and hyperlipidemia. Her past mental health history is insomnia, generalized anxiety disorder, severe recurrent major depression without psychotic features, bipolar 1 disorder, panic disorder, post-traumatic stress disorder, previous suicide attempt, and sexual abuse. History and physical medications is her gemfibrozil 600, hydroxyzine HCl, lovastatin, omeprazole, ondansetron, propranolol, Requip, Seroquel, tizanidine, topamites, and Effexor. Her drug allergies are aspirin. Her family history is currently, she's in her 4th marriage, married for 5 years, has 3 daughters. One daughter has spina bifida, daughter with endometriosis, a daughter in the military, and she's deployed to Turkey. Her parents divorced when patient was 5. Father has heart disease, mother has colon cancer. Her social history is never smoked, occasionally use caffeine, and does not use alcohol. Assessment, vital signs, her blood pressure was 123/86, her heart rate 79, denies any pain at this time. Her height is 5 feet 2 inches, weight 173.3, and BMI 31.7. Her mental status exam, she appeared well groomed, clean, and overweight. Behavior was cooperative, calm, and with good eye contact. Speech was fluent, clear, and normal volume. Perception, no hallucinations. Cognition, she was oriented to situation, time, place, and person, and alert, and memory impaired. Intelligence was average. Mood was irritable and frustrated. AFAT was anxious and angry and euphoric and congruent to thought content. Insight, intake, judgment was intake. Thought process was intake. Thought content unremarkable, and motor activity intake. Differential diagnosis is mood disorder due to general medical condition, substance-induced mood disorder, and dysthymic disorder. Plan of care was going to allow brain to reset, slowly tapering patient off venlafaxine, ER 75 milligrams until her antidepressant is discontinued. We're going to continue the Seroquel 200 daily. We're going to continue the ropinirole 1 milligram tablet daily, and refer patient for trauma focused CBT. Return to clinic in 1 month to reassess patient, and when TMS is available in an outpatient clinic in September, start patient on high frequency RTMS daily for 5 weeks. Barker's title model of mental health recovery. Barker's title model is applied to those case studies because the theory focuses on the difficulties and experiences this patient has experienced in her life. This model believes we must try to control our lives. Our lives are constantly changing, although we like to believe that certain things are fixed or stable, but things are moving all the time. Recognizing that we are in a state of flux, the title model believes we must try to control our lives. We need to work out how we navigate our way through all storms and challenges that life presents to us. This model's focus is to help this patient tell her story on what she has experienced and how it has affected her, and find out what kind of help she may need to help her begin to move on. This patient has been blown off course, and she strongly believes that she may never get back on course. This model will help her to tell the provider what may be useful to help her get back on course, and most importantly, help her realize what resources she has within herself to help her recover from a long-standing history of treatment-resistant depression. This model will help correct this patient's faulty thinking. Focused clinical PICO question is, in adult patients with treatment-resistant depression, how effective is combination therapy using antidepressants compared to antidepressant augmented with transcranial magnetic stimulation in the prevention of this illness? Evidence-based research criteria. Databases used in this case study included Academic Search, CINAHL, ProQuest Central, and EBSCO hosts on the subject of medicine and health. Randomized clinical trials, systematic reviews, and meta-analysis literature were all analyzed. Keywords used in the search was transcranial magnetic stimulation, treatment-resistant depression, antidepressant, major depressive disorder treatment, combining antidepressant. The case study includes patients' age, co-occurring disorders, predisposing factors such as duration of bipolar disorder, duration of generalized anxiety, duration of major depressive disorder, previous treatments for disorder, lab values, patient's overall view of her illness, initial psychiatric visit. Purpose of this evidence-based research is patient voices complaints of major depressive disorder that has been untreated for over 15 years. Patient has an underlying bipolar disorder. Mania is effectively managed. Patient has a poor quality of life, feels hopeless due to numerous failed past treatments. Confirmed potency of TMS augmented with antidepressants in comparison to combination therapy used in antidepressants. Educate the patient on the effectiveness of TMS in treatment-resistant depression. Transcranial magnetic stimulation. TMS is a non-invasive procedure that uses powerful focus, magnetic field pulses, and induce electrical currents in target brain regions. The pulses are delivered via a handheld or helmet-shaped induction coil placed against the scalp of the target area. Signal RTMS pulses are powerful enough to induce action potentials in the target region. Repeated trains of pulses causes changes in synaptic connections via the mechanism of neuroplasticity. High frequency stimulation is considered excitatory, and low frequency stimulation inhibitory. Multiple sessions of RTMS delivered over several days can produce durable increases or decreases in the activity of target brain region, lasting weeks to months. Repetitive transcranial magnetic stimulation can thus normalize the activity of frontal lobe regions that are hyperactive or hypoactive in major depressive disorder. A few current uses: major depression, FDA approved, anxiety, chronic low back pain, auditory hallucinations, schizophrenia. Evidence-based findings. Transcranial magnetic stimulation with antidepressants, non-invasive, very few adverse side effects, increased compliance with dropouts in treatment-resistant depression, increased antidepressant response, and consistent decrease in symptoms of major depression. TMS over the left dorsolateral prefrontal cortex may have long-term antidepressant effects. Active TMS produced a significant improvement of depressive symptoms that last for 6 months, and 50% mean scores in both HAM-D and MAD-RS between weeks 4 and 6 of active treatment. Combination antidepressants as treatment of TRD as first option remains questionable. No mean change in MAD-RS after week 6. More effective when combined with atypical antidepressants compared to other antipsychotics compared to other antidepressants. Greater side effects burden including serotonergic syndrome and syndrome of inappropriate antidiuretic hormone secretion. Key research findings. The evidence-based research collected affirmed TMS argument with antidepressants is more effective treatment for treatment-resistant depression. Research findings show that both TMS augmented with antidepressants and combination antidepressant therapy are both effective in treating TRD, but evidence also reveals a partial response in TRD with combination antidepressants. One study shows augmentative RTMS after the failure of medications significantly increases the effect of antidepressants, and RTMS was a safe strategy with relative low adverse effects and low dropout rate. Multiple studies consistently show TMS augmented with antidepressants provide a notable change in symptoms of depression. Analysis show high frequency RTMS over the left DLPFC may have long-term antidepressant effects in drug-resistant MDD. Implementing findings to the case study. Findings In this research showed transcranial magnetic stimulation augmented with antidepressants is more effective in treating treatment-resistant depression than combination antidepressants. In the past 15 years, the patient has failed numerous treatments with most classes of antidepressants and augmentation with other medications, including antipsychotics. During visit, the patient scored 27 on Hamilton Depression Rating Scale. According to evidence in case study, patient will be a great candidate for TMS treatment. According to evidence in this case study, patient will benefit from RTMS with an intensity of 80% or 110% of motor threshold at 20 Hertz over the left dorsolateral prefrontal cortex. These are my references. And I want to thank you for listening to this presentation. I hope this presentation was knowledgeable and educational. And if you have any questions, please feel free to ask, and I will try to answer them to the best of my ability.